Okay, so let's talk, or at least begin talking about interprofessional care when people who have oncology problems. And the reason why I said we might just be starting is because the interprofessional care associated with these clients is huge. It's enormous. So in terms of interprofessional care, this is why I thought we would maybe be needing more than one video about interprofessional care. These are the goals of cancer treatment. This is a lot. So there's a few different overall big goals of cancer treatment. We're either going to be shooting for a cure, we can be shooting for control, or we can be shooting for palliation, which is comfort. So we are either going cure, control, or comfort. 9 times, or not 9 times out of 10, I'm not going to give you ratios on that, but more often what's happened is these people have gone through their initial treatment phase before we even begin to start figuring out what goals they can would be appropriate. So they may have been having some immunotherapy, targeted therapy. Maybe they had a surgery. Maybe they've had some chemo. There's a variety of different treatment phases, or not treatment phases, but there's a variety of different interventions that we can be using in that initial treatment phase. We can also use the different goals in combination with one another too. And just because we can, we might be shooting for cure, but it might not work. So then we go to control, and that may or may not work. So then we go to comfort. Just so that you're aware, any of the interventions that you see here, basically the interventions are the things, or the goals that are circled in red. Anything that's not circled in red is a potential treatment and a potential intervention, which is why teamwork is so huge for people with cancer. Let's see here. So the goals of cancer treatment and interdisciplinary teamwork are, like I said, curative therapy, where we're going for a cure. It could be from surgery alone. It could be for periods of systemic therapy. So like we'll have a cluster of chemotherapy, radiation. They'll take a break and let the body recover, and then they'll go back again. And depending upon how everything's progressing, they may do multiple rounds of treatment. If you've heard people getting rounds of chemotherapy and rounds of radiation therapy, that's what they're talking about, is these periods of systemic therapy. We can also be going into control mode, where we're doing a maintenance therapy after an initial course. And then if for whatever reason the client has a different set of goals, then maybe curative or control therapy. If they just want to be kept comfortable, that's a palliation goal. Just so that you're aware, palliative care and treatment aren't mutually exclusive. So palliative care, this palliation goal, does not mean hospice, and it does not mean end of life. So you can have people on curative treatment and still be getting comfort, or curative goals and still be getting comfort goals too. It's a very important distinction to understand, that these three can all go together. They're not one or the other. So methods used to meet these goals, and there's a variety of different things that people can use to be able to meet the goals. From personalized cancer medicine, where we're actually taking a look at remember when I said way back in the first slideshow about depending upon where the cell cycle is, we'll actually have different targeted therapies. That's what I was talking about. So personalized cancer medicine, where's that tumor at? What sort of cell cycle is that tumor displaying right now? That's what we're going to hit it with. And then we'll keep moving on from there. And then after a certain amount of time, We'll do a quick check, see if we can get some more cells in that one specific M phase, and then we'll hit it again. Chemotherapy is a generalized, typically a generalized infusion that's given over a certain amount of time. Chemotherapy targets all rapidly dividing cells in the body. So whether it's your hair cells or your hair follicle cells, or another area of rapidly dividing cells are your cardiac muscle cells, the linings of your stomach and your intestines are rapidly dividing cells, as well as your testicles are your spermatogenesis is a rapidly developing or dividing cell. So as well as ovaries and eggs. So chemotherapy will impact all of those, because chemotherapy does not care what type of rapidly dividing cell you are, it's going to get you. There is surgery where we excise and remove the tumor. There's radiation where we use specific beams of energy to be able to take out the cell, or to kill the tumor causing cells. Other types of radiation include like implantable radiation as well. So sometimes people with prostate cancer, which we'll talk about when we talk about reproductive problems in males, but prostate cancer can sometimes be treated with things that look almost like flax seeds, but those little flax seeds are actually radioactive seeds, and the radioactive seeds get implanted into the prostate and take care of the tumor from the inside out. We can use hormone therapy. We can use immunotherapy to strengthen the body's immune system and tweak the body's immune system to attack the cancer cells. And so amazing. We can use hemopoietic growth factors, and we can use stem cell transplants. Those are very common with bone marrow cancers and leukemias, as well as gene therapy. So we can use a variety of different interventions to be able to help people meet their cancer goals. The role of surgery in cancer treatment is multi-focused. It can be for prevention. So let's say somebody does a genetic test and finds that they're carrying the BRCA gene. They may decide to do a preventative surgery to remove the organs to prevent developing breast cancer in the first place. So I know that one of the most famous cases, and she's been very public about this, so I'll share this. So Angelina Jolie is an actress, and she had tested positive for the BRCA gene. So she had her female reproductive organs, including her ovaries, fallopian tubes, uterus, and she had her breasts removed so that she could not develop, to be able to prevent any sort of cancer because she has that gene. You can also have a surgery to determine the diagnostic and treatment plan. Surgery can be curative or controlling through removing that localized cancer tissue. It can be supportive. So like, let's say for whatever reason you have somebody who has esophageal cancer, we can insert a PEG tube, a percutaneous enterogastro tube, into this wall of the stomach, so that way they can still get nutrition through their stomach without needing to swallow because they have esophageal cancer. There's rehabilitative and reconstructive surgery. So in addition to the preventative surgery that Angelina Jolie had, she did have some reconstructive surgery. And now she has breast implants to be able to still present to the world the way she wants to. And then there's also palliation of symptoms. So sometimes those tumors are growing and they're pushing on nerves, like I said, and they're very painful, or they're even creating problems with swallowing difficulty. So you can actually remove that tumor through surgery and restore that nerve function and remove that pain. In addition to what we figure out with the biopsy and with diagnosis. Goals of chemotherapy is chemotherapy. If we're using it for we are using it for 3 different reasons. Again, this is how it fits into the 3 different reasons. Chemotherapy can be used to cure a lot of leukemias, testicular cancer, lymphomas, neuroblastoma. It can be used to control breast cancer, non-Hodgkin's lymphoma, small cell lung cancer, and ovarian cancer. So these people aren't necessarily taking chemotherapy to necessarily cure themselves, but to really just keep that control situation going. They don't have metastasis to other places, and they don't have the tumors that they have grow. And perhaps they shrink just a little bit, but it's all about control. It's not about curing. And then we can also have palliative chemotherapy too, where that chemotherapy is used to relieve pain and improve a sense of well-being through that obstruction being removed. There are some classifications for chemo. It's classified by the molecular structure, and it's classified by the mechanism of action. And there's 2 major categories. There's either cell phase non-specific or cell phase specific. So depending upon where the tumor is at, or what sort of cell phase we think that the tumor is going through its life cycle, we can give that cell phase specific. We can also administer cell phase non-specific. Typically, there's a combination of these. So if they're coming in for their first round of chemo, they're probably getting both, and then they'll undergo some tests, see where things are at. And for a second round of chemo, it could be that it's a combination of both again. It could just be that it's non-specific. So some of this is outside of our control as nurses because it's very provider order. It depends a lot on provider orders and a lot of diagnostics. However, when it comes to the administration, we are in charge of administration. So if to administer chemo, you must be specifically trained. There's a whole certification process that goes along with chemo administration. There are oral pills. The oral pills, they have more and more options available by the day. There are some storage, there are some side effects that we need to be aware of. And some of those oral pills are so specific and not really out in the general world that, let's say we have a person who is hospitalized for a non-cancer related thing, but they're on like a preventative or controlling chemotherapy agent for breast cancer. Pharmacy may not have it in stock. So pharmacy may ask the client to bring that in, and then they would have their own chemotherapy pills that they're taking. We can give it IM. You can give chemotherapy IM. It's not used very often. And IV is the most common administration for chemotherapy. Let's talk about the big picture, like legit on the right side of your screen. So this is extravasation injury due to chemotherapy. What happened was that this person had a peripherally inserted IV and in their hand, as you can tell. And the chemotherapy didn't stay where it was supposed to. It leaked out into this interstitial area, got outside of the blood vessel, and then destroyed the person's subcutaneous tissue and epithelial tissues as well. That's why a lot of people who are getting IV chemo will have a central venous access device. More often than not, they'll have a port, which is like a button that usually sits right over here or just off to one or the other sides of the sternum, depending upon surgeon preference. They may have a subclavian right here underneath their clavicle. They may have a PICC line, but more often than not, they have a port because the port is able to be completely encased by the skin. And then it's just accessed via a special needle. Therefore, there's less chance for blood infection from CLABSIs, from central line associated blood infections, because when that port isn't accessed, there's no other openings to the skin. Whereas with a subclavian line or a PICC line, you have that little hole that line is entering the body through. You can also use their central venous access devices for other blood and electrolytes and fluids and such, but be careful that the chemo nurse doesn't need it, because the chemo nurse could need it, and then you have to have a peripheral for your blood products or your electrolytes or whatever. So chemotherapy effects on normal tissue. Like I said earlier, chemotherapy agents can't distinguish between the non-specific ones. And even the specific ones, they can't tell the difference between normal cells and cancer cells. So the side effects are results of destruction of the normal cells. Bone marrow, lining of the gastrointestinal system, and the skin, hair, and nails are all friendly fire casualties when it comes to when we're waging war with chemotherapy against cancer. So there are some specific adverse effects, and they're classified depending upon how fast they come on and how long they last. So you can have acute effects, you can have delayed effects, and then you can also have chronic effects too of therapy on that normal tissue. So I'm going to stop sharing and stop recording here, and then I'll start talking about radiation in just a moment.